Hello, my name is Araxie Matossian. I'm working in Belgium and in an adult CF center in Brussels. I would like to thank the organizers for inviting me here in Thessaloniki. Thessaloniki is a city I know very, very well because I was born and grew up in Greece, only 120 kilometers in the beautiful Kavala. Thessaloniki was always for me the city of adolescent explorations. So today I will talk about adult life, adult CF life within the family. CF, like suffering of body and mind. I will do a little brief sidestep on emotional distress, and I will talk about patient and healthcare provider, and a little word on endurance. So, life is a cycle, and adult life is a natural life cycle, alternating periods of building and maintaining and changing life structures. During these periods, an adult complete education, maintain relationships with his parents and siblings, may leave home, develop intimate peer relationships, get a work, independence, a partner, and explore life practically and emotionally. Can live a childless couple life, having a child and a family, and this life goes on until they get very old. A CF adult life is sort of double life. It's a progressive, double life as patients are facing a progressive lethal illness, with comorbidities increasing, with more symptoms, some of them visible, most of them concealable, more treatments, pain, a lot of pain, physical and psychological pain, and sleeping problems. Of course, many patients can fulfill adult life tasks, making choices like healthy people, but these are always implicated by CF and CF treatment. So, as life goes on, a CF patient has to face multiple successive new diagnoses. He may give up on plans and dreams, dreams like education, dreams like work they want to do, or even independence. An adult CF patient may not leave home because they may feel more secure living with parents. Also, when the illness is severe, it's very difficult to keep up with healthy friends' rhythm, and so getting more isolated. Of course, intimate and sexual relationships is an issue. So, as life goes on, the future may be uncertain. Actually, I would say we have some generations with different reality. So, we have the new generation, like from 0 to 20. Of course, I mean, I'm talking about a reality I live since 15 years. So, this for us is a new generation of young people evolving in CF centers since they are born. From 20 to 35 it's a generation what I call the mature adolescents. So on their 20s, patients are exploring liberty. They go for more education or they get a work, and they usually try to leave and certainly try to forget about CF and treatment. Of course, what happens at these years is that they are caught up by anxiety at some stage because of the fact that they know about their life expectancy. They know that life expectancy actually is something like 33 or 35 years old. And then we have our generation of 40s and more and 50s or more, and these are survivors because they are living longer than expected. they certainly heard that they could have died when they were a child. They are pretty much invincible. So, we also have many patients, and I don't know how many patients like that you have in Greece, but patients that are diagnosed in adult life. So these are patients that have generally achieved part of their lives, and then diagnosis comes after a long period of suffering from symptoms that are misdiagnosed or mistreated. So I would say these patients are, it's a long journey till they get to the diagnosis where they felt bodily sensations that has not been recognized as such, and they couldn't be linked with the diagnosis and treatment. So when the diagnosis is there, of course patients feel relief, certainly, because now they have a name of the disease and the treatment, but mostly is a shock. Is a shock because they have a diagnosis with a lethal illness, and life seems to be very short. At that stage of their lives, patients and their family need a specific professional support, and of course they need time. We have many examples in our clinic of patients that, of course, we think they should be relieved knowing that they are cystic fibrosis, because one of them, a young lady of 23 years old, she was an etiquette, a label, like she was depressed and a little bit doulali, I would say, because she was going on, what they prescribed is psychiatric ward. And then, of course, cystic fibrosis was relief for her because she wasn't crazy, not depressed, but she was just cystic fibrosis patient. But still now, 3 years after, it's very difficult for her to accept and adapt. So, an adult CF patient, it's bearing his own family history. It starts early. Family history is the way a whole family is concerned from the illness, the way the whole family face, adapt, cope, institute care, integrate CF in the family, and in the family's interactive function. So that's the early family context that influences attitudes towards life and illness, that shapes resilience and vulnerability. And I would like to give the example of a patient. He's now 45 years old, or more, I think 48 years old, transplanted patient. And his sister died when he was 16, and he's from CF. And his brother died also when he was 20 years old, from CF also. And he's always said to me, my mother was keeping telling me that I was different and I will survive, even though he has the same mutation with his brother and sister. And he's always saying, this comment of my mother made me what I am, determined to survive. So, during adulthood, CF may affect patients' relationship with their family of origin or present family. So that CF may modify roles. A patient can, an adult patient may become the patient of his beloved partner. So he's changing his role of the partner, and he becomes more a patient. That's very difficult. It's also some adults have, even though they are not living home, they are not living with their parents, they have to go back, and getting back with mom and dad, it's not so easy. So CF causes stress and pain, and may negatively affect the attachment of the family members because of the fears of separation and loss. some patients also are concealing information from their family to prevent, they say to prevent the family from strong emotions. Of course, it's to protect the family, but also protecting themselves. And here I have the example of a young 28 years old patient who was referred for transplantation, and he didn't want to talk about it with his mother because he was afraid that that will bring back bad memories for his mother, because his sister died after transplantation a few years ago. So, exploring a patient's family functioning, early or actual family, and interactions may help us to understand patients' reactions, perceptions, beliefs, which is very important, and of course decisions they make. Another very specific, I would say, aspect of the CF patients is what I name suffering of body and mind. That means even for patients which are not severely attained from CF, I would say, but even then they are never able to forget their own body. They can never be at rest. Their body doesn't work in silence and secrecy. Let's think about, the healthy people of this room, which are not CF, we never think about breathing, unless if we are having something like bronchitis or something when we are sick. Otherwise, we never think about our lung functioning. So, CF is a sort of suffering inside their bodies, but also in relation to the environment, family or social. Because, think of the patients are coughing during a movie. I would say patients are very often say, I'm really fed up of the sad and compassionate glance people can have on me. And I would add, sometimes the glances of other people are either frightened because they feel they could be contaminated for something, from one illness, or even angry because coughing is disturbing. So, during the adult life, a patient is constantly and dynamically shifting between periods of being sorely afflicted by CF and treatment, and periods of suppressing it completely from his consciousness. Of course, I would say it's an antagonistic attitude, but it's very important and absolutely necessary to balance the disease management for the patient and a normal life as possible. So, life with this way of life with CF is vital, because it's very important not to be overwhelmed continuously with emotions like frustration, anger, worry, or anxiety. So, throughout the illness evolution, and depending, of course, on the circumstances, a patient reacts in a continuum between denial, avoidance, and accurate concern. You can see denial is in red, because denial and avoidance upset terribly the healthcare providers. A lot of them think denial is maladaptive, and some studies have said things like that. And it's, of course, very important denial may be maladaptive. But I would say with some other studies, and of course with our experience of the practice on the clinic, I would say a little dose of denial helps people to feel more in control, feel less anxiety, and increase self-esteem, and may have a better quality of life. So, living an adult life with CF is an ongoing, ever-changing process between the perception of being well and the perception of being sick. I will put here my sidestep about anxiety, depression, and emotional distress. So, anxiety and depression are major psychosocial aspects of CF, and a lot of things have been said and studies have been done around anxiety in national level or international level. I would say that anxiety, of course, having intermittent symptoms of anxiety does not mean clinical anxiety and depression. And Maya said that in her presentation. We have fluctuating periods of being very anxious or depressed and then being a lot better and forgetting about it. So that's why I prefer to talk today about emotional distress. So emotional distress, it's a natural reaction, negative but natural, who points out difficulty to adapt to CF, evolution and treatment. Emotional distress presents various emotions and fears and questions. Why me? Why now? Why again? I would like to be normal. I mean, CF ruins my life. So, emotional distress, of course, induces loss of control and may lead to anxiety and depression. May be over or underestimated, but certainly may be influenced by communication strategies, which I will explain a little bit later. But emotional distress of the patient induces reactions to the team. That's for certain. Like said Maya a little earlier, it's hello, the psychologist, we have a problem because the patient is crying. So, don't panic, just organize. So, how we can be organized is the communication strategies, which I will say a little bit later. So, here we come with CF patient and healthcare provider. It's a CF patient, important part of the adult patient's life is interacting with the team, the healthcare providers. This interaction contains an intersubjective relationship between them, patient and healthcare provider. They both influence one another and build up a therapeutic treatment process. So, in this therapeutic treatment process, two questions are very important. Are we just treating an illness? Which is a very dynamic process, I would say, because we are fighting against illness, we have tools, and we are doing okay, and that gives reality, but also illusion of avoiding suffering. Or, the second question, are we caring for the person? Which is how the way we are focused on what the patient experiences. That means we have to attend the suffering and certainly being affected by it. So, patients and healthcare providers evolve together. They are both involved in the treatment process by actively thinking and participating in it. The interactions between patients and healthcare providers influence quality of the CF treatment process, and of course the well-being of both patients but also healthcare providers. A very important issue in this therapeutic process is time. Time is a real issue because patients need and take time to cross the steps, to accept and adhere. Time is not going, it runs differently for the doctors and for the healthcare providers, of course, because we are seeing a little bit more farther, so we need to go faster. Adherence, it's a very also major psychosocial topic. in cystic fibrosis. Usually, adherence undermines relationship between patients and healthcare provider. It's a major, major challenge because of the fact that adherence is low in cystic fibrosis, but not only. Adherence is low in all chronic illness. It's something like 50% of what is expected in all chronic illness that patients are doing. But it's also important, let's think, how many of us deciding resolutions every New Year or every September or after vacations, I don't know, and how many of us we can stick on these resolutions? Some people are saying not even 20% of us doing that. So, many studies are being conducted for this topic. I won't say, I will briefly just say that the important part is that some predictors of adherence, like emotions, shame or fear, family and social support, perception of control, and physician's empathy. Another relevant finding from the studies is that interventions to improve adherence should be treatment tailored to the patient, and of course, individual and family approach is the best way to work on adherence. I'm saying something about motivational interviewing because, like I said earlier about the communication strategies, so motivational interviewing it's a communication tool. It's a successful one, and I would say certainly for persons, for non-psychologists, for doctors, physicians, dietitians. It's a very successful tool to communicate with the patient and try to understand why a patient does or does not something they wanted them to do. Motivational interviewing is very effectively used in the field of CF, especially in UK, in United Kingdom. To conclude, I would say that the emotional well-being of the adult patient fluctuates over time and interacts with the severity of the CF, with patient's personality, social role, coping style, but certainly with the medical, psychological, and social support system. CF care is a subtle balance between science, commitment, and creativity. Thank you.
Thank you very much. You were so kind to ask me in the beginning of your presentation. She said, give me a warning if I'm 10 minutes from the end of my presentation, but you were even earlier. So that leaves
I wanted this to get a little bit more interactive.
That would be very interesting. So maybe please, if there's any questions from you, the audience, to start with, and then maybe you have some questions too. Are there any questions from the audience about this talk? No? Nobody? Oh, there's a question. But maybe if you start walking up here, I start walking to you, and we meet in the middle. Okay, I'm sorry.
Γεια σας. Θα ήθελα να ρωτήσω πώς μπορούμε να πείσουμε έναν ενήλικα ασθενή που έχει παρατήσει πλέον τη θεραπεία του, είτε γιατί φοβάται, είτε γιατί δεν θέλει, είτε γιατί έχει κουραστεί πλέον, το να συνομιλήσει με κάποιο ψυχολόγο ή με κάποιο ψυχίατρο, γιατί δυστυχώς στη νοσοκομιακή περίθαλψη δεν δίνεται αυτή η δυνατότητα στην Ελλάδα, τουλάχιστον στο μέρος που είμαι εγώ στην επαρχία δεν μας δίνεται τόσο αυτή η δυνατότητα. Και όταν το ζητήσαμε επανειλημμένο, κάποια στιγμή έγινε κάποια προσέγγιση, αλλά του στείλει «Γεια σας, είμαι ο ψυχίατρος τάδε, τι σας συμβαίνει, πείτε μου». Ο αδερφός μου δεν ήταν ούτε έτοιμος, αλλά ούτε και ήθελε να συνομιλήσει με κάποιο ψυχολόγο, γιατί θεωρεί ότι δεν χρειάζεται ψυχολογική υποστήριξη, παρόλο που έχει παραμελήσει την θεραπεία του πάρα πολύ και έχει χειροτερέψει πάρα πολύ η κατάστασή του. Ευχαριστώ.
Okay, the question was, I will briefly introduce it, is about an adult CF patient who's non-adherent at all with his treatment anymore, and he doesn't want to talk about it, to meet some psychiatrist or some psychologist, and the question is how we can convince him. Wow. Very good question. I don't really have, an answer. I could say that it's very important to first to think how long the patient was non-adherent or is non-adherent. And to try, it's very difficult. The lady said also that he once met a psychiatrist, and then the psychiatrist said, "Hello, yes, what can I do for you?" It's usually in the centers when psychologists or psychiatrists are used to work with CF patients. We never ask that question like that. They never ask to see us. It's not, like I said earlier, it's not a Greek thing, doesn't want seeing a psychologist. It's for everybody. Why? What a psychologist can do? Could he change CF? Could he cure me? Could he change my life or my miserable life if they feel miserable? So I think it's important not to give up and try to stay. Because the lady said that was her brother. I think the family support and trying to convince. I think it's not the professionals will do the job. It's the family will try to go perhaps with part of the family to meet somebody, or to go and meet somebody in Greece who knows about cystic fibrosis, a psychologist, who is working already. It's very important not. When psychologists, usually when the patients are coming to us, we say, "Oh, hello, what can I do for you? Why did you come see me?" It's not like that, but what brings you to me? But it's a question that we can't really, we never ask to cystic fibrosis persons.
Maya would like to make a remark on that.
Yes, we're going to talk between psychologists now. So, I'm going to ask a question to the woman that just talked, and I'm truly sorry if it sounds violent, but I think it's supposed to be a bit provocative. I don't see you, I don't know who speaks. But my question is, why should your brother go and see a psychologist? As you said, he's an adult, so he can actually decide for himself if he wants to be adherent. Again, I'm really provocative because I'm looking for something, of course, behind this very potentially violent question. Why should we, adults, force another adult to go and see a psychologist as he's living his life the way he wants to?
Would you like to give an answer on that?
Πιστεύω ότι βασικά το έχω σκεφτεί έτσι, γιατί μέχρι πριν από λίγα χρόνια, πριν από 3 χρόνια, προσπαθούσε γι' αυτό, για τη θεραπεία του και ήταν σχετικά καλά. Δεν ξέρω, κάποια γεγονότα στη ζωή του, κάποιοι φίλοι του που παντρεύτηκαν και φύγανε, έχει πέσει πάρα πολύ η ψυχολογία του, και εμείς σαν οικογένεια, αδέρφια, γιατί είμαστε 2 αδερφές ακόμη, όσο και να προσπαθούμε να τον στηρίξουμε γι' αυτό, δεν βλέπουμε κάτι ότι μπορούμε να κάνουμε κάτι περισσότερο, να είμαστε πάντα κοντά του και να μιλήσουμε μαζί του, και ό,τι θέλει. Είναι πολύ αθλητικός και στην επικοινωνία με την οικογένειά του πλέον. Χωρίς δηλαδή να έχουμε, θεωρούμε τουλάχιστον εμείς, δεν ξέρω, και αν κάνουμε κάτι, το ρωτάμε και του λέμε να μας πει τι τον ενοχλεί από εμάς. Έχουμε συναντήσει ψυχολόγο και ψυχίατρο έξω εκτός νοσοκομείου, για να συμβουλευτούμε, να δούμε τι πρέπει να κάνουμε, τι φταίει, αν φταίει κάτι στη συμπεριφορά μας, Και όλοι μας λένε ότι ό,τι και να κάνετε εσείς, το θέμα είναι ότι πρέπει να μιλήσουμε με τον ίδιο τον ασθενή. Αλλά εμείς τον ίδιο ασθενή δεν μπορούμε να το πείσουμε να συνομιλήσει με κάποιον ειδικό. Γιατί θεωρεί ότι δεν είναι απαραίτητο. Και μας λέει ότι δεν έχω τίποτα, δεν συμβαίνει τίποτα, ενώ ούτε κάνει τη θεραπεία του, ούτε και τρέφεται σωστά, δεν κοιμάται, κάθε βράδυ πλέον δεν κοιμάται τα βράδια. Είναι άϊπνος και βλέπουμε ότι έχει ένα φόβο για την ασθένεια. Παρ' όλα αυτά όμως δεν έχει μοιραστεί με κανένα. Ευχαριστώ.
Μία ερώτηση θα σας κάνω. Πόσο καιρό είναι έτσι ο αδερφός σας? 2 χρόνια. Και πόσο χρόνο είναι? So, the brother is 32 and since 2 years, I mean, it's very important. Maya it was provocative, but it's true. We can't force somebody to go to the psychologist, but of course, the psychologist could help him. I mean, probably the person may be depressed for several reasons. I mean, his own reasons, and he might need, help, and not only chemical help, I would say, but talking about his feelings, his fears. The age is, it's a pretty old adult, and probably our life expectancy issues and other questions are there. But that's true that you can't worry. I mean, you worry, but you can't do anything. But being by his side constantly and being there, he might come to this idea to see somebody a little bit later. But for the moment, depressed people don't want to go to see somebody usually when it's not on the use, I would say, on the practical use of their living.
Yes, I just wanted to add that maybe you could also go to get support and to find with a psychologist very key solution to help him, to support him.
I feel sorry for you and your brother, of course, and I wish you strength and wisdom and help. Do you have another question for the audience, maybe?
I have questions. I thought the audience could have questions.
Are there questions from the audience?
Perhaps one. How many adult patients are here? Could you raise?
How many adult patients we have? 1, 2, 3, 4, 5, 6, 10, about 10. You have a question for them? Okay. Last chance now. We are questions, or we move on with the next presentation. Thank you very much.